Welcome to the System Podcast. This is the revision series for O and G, and today we'll be talking about management of uterine fibroids. As you know, we follow the outline through introduction, history, physical examination, diagnosis or differential diagnosis, investigation, and treatment. Now, uterine fibroids, as you all know, is a very common condition which normally occurs to women who are aged, mostly postmenopausal women. So we'll go straight to the history. As you know, history is more of like the symptoms plus some other risk factors, trying to dig out to know the reason why something has happened and to tie up everything to get a logical diagnosis. So they can present with abnormal uterine bleeding. When we say abnormal uterine bleeding, normally women bleed monthly, which is the menstrual bleeding. But in a case whereby there will be abnormal bleeding, which could be postmenopausal bleeding in women who have already reached menopause, or intramenstrual bleeding, then you can be able to think that there is a likely possibility of uterine fibroid. And reproductive failure can occur when the fibroid grow to block the fallopian tube and the sperm cannot reach. Then they can also have recurrent pregnancy loss. That is, miscarriage is a cause of miscarriage. The bulk effect on adjacent structures in the pelvis, that's pains because of the pressure effect on them. The bladder and bowel dysfunction, they can have bladder dysfunction and bowel dysfunction. As you all know, the uterus sits in between these two structures. So we go to this physical examination. On general physical examination, because of the consistent loss of blood, the woman can have anemia. Under the abdominal examination, can be visible or palpable abdominal mass which arises from the pelvis. For the bimanual examination is simply the examination which is done for the pelvic examination, which one hand is put into the introitus and the other hand above to be able to palpate. You will be able to palpate enlarged frame, smooth or irregular non-tender, and uterus will be palpable. So the mass is enlarged, firm, smooth or irregular. It could be smooth or irregular, and it's normally non-tender. So the next is the diagnosis. We can establish a diagnosis using our history and physical examination for uterine fibroids. So, and full blood count is needed when there is history of menstrual bleeding. When there is history of heavy menstrual bleeding, abdominal pelvic ultrasound can be done. This is the mainstay for the diagnosis, and you can either do the transvaginal ultrasound scan or transabdominal ultrasound scan. Now, it helps to delineate the origin of a clinically detected pelvic mass. That is distinguishing between a uterine fibroid and an ovarian tumor, and locating the position and size of the fibroids. It helps to do all this. So in presence of large fibroids, ultrasonography is also helpful to exclude hydronephrosis from pressure on the ureters. Now you do it to kind of exclude that. As we all know, hydronephrosis is very bad. It can that's accumulation of fluid or the urine in the kidney. Now for the treatment, as you all know, after diagnosis and investigation, go to the treatment. We can divide this treatment into either three modalities. We have the medical, we have the surgical, and we have the radiological. So let's start with the medical. Now the medical treatment, which is also known as the conservative management, for asymptomatic fibroids that are detected incidentally. If they are asymptomatic, so you don't expect them to present, so it's incidentally that it's been detected. For those with heavy menstrual bleeding, treatment is usually levonorgestrel intrauterine system. So you use the levonorgestrel intrauterine system, tranexamic acid, which is also a drug which reduces bleeding, mefenamic acid, and combined oral contraceptive pill. This is what we use for the conservative treatment. For surgical treatment, the choice is determined by the presenting complaint, yeah, and it's also determined by the patient's aspiration for menstrual function and fertility. Okay, now minimal invasive hysteroscopic surgery. So you can do the minimal invasive. Hysteroscopy is just a way to view the uterus. So as hysteroscopic surgery, you are viewing and you are doing the surgery where a bulky fibroid uterus causes pressure symptoms, or where heavy menstrual bleeding is refractory to medical interventions. The options are myomectomy. Myomectomy is just from the word myomectomy, that's removal of myoma, which is the uterine fibroid, to surgically remove. Now myomectomy to surgically remove. Then next is where preservation of fertility is required. Myomectomy is best option. For radiological uterine artery embolization, it's what is being done. So thank you all for listening to this short management of uterine fibroid, which is part of the revision series. I'd like you all to like, subscribe, and follow us on Facebook, and leave a comment. Thank you very much.